Inguinal hernias. So it is much more common in male compared to your female with a ratio of 10:1. Now before we go for the discussion of your inguinal hernia, let's understand the anatomy of your inguinal canal in form of your salient basic points. So first we have your deep inguinal ring. It is a defect in your transversalis fascia. It lies deep to the abdominal muscles and midway between the ASIS and your pubic tubercle, which is around 2 to 3 centimeter above marginally and lateral to your femoral artery pulsation. Now, if you look at this diagram, this shows your close relationship of your direct inguinal and your indirect inguinal femoral hernia. So, you have your femoral inferior epigastric vessels which lies medial to your deep inguinal ring, and it passes from your iliacus to your rectus abdominis. Now, this image shows your anatomy of your various important structures in your right inguinal space. So, this is your area of your direct hernia, which is your Hasselbalch's triangles, which we shall discuss subsequently, and this is your area of your indirect hernia. So, we have your pubic tubercle over here and the edge of the inguinal ligament, and you have your inferior epigastric vessels present over here, and your various important nerves are your femoral nerve, femoral branch of your genitofemoral nerve, and your genital branch of your genitofemoral nerve, and this is often referred to as your danger zone. Now, the roof of your inguinal canal is formed by your conjoint tendon, and this conjoint tendon is your fusion of your transversus and your internal oblique muscle. Then you have your posterior wall, which is formed by your transversalis fascia. Your anterior wall is formed by your external oblique aponeurosis, and your floor is formed by your free edge of the external oblique aponeurosis, which is rolled inwards and thickened to become your inguinal ligament. Now, what is your content of this inguinal canal? So, we have your spermatic cord, which consists of your testicular artery, vein, lymphatics, vas deferens, and all coverings in form of your cremastric muscle. In case of your female, we have your round ligament as the content of your inguinal canal. So, this is again the same diagram that we had discussed prior, showing your important relations of your important preperitoneal structures in your right inguinal space and your important nerves, which are your femoral nerve, femoral branch of genitofemoral nerve, and your genital branch of your genitofemoral nerve. Now, the two types of inguinal hernia, which is your indirect and your direct. So, indirect inguinal hernia is basically lateral, that is they lie lateral to your inferior epigastric vessels, whereas your direct inguinal hernia are medial as they lie your medial to inferior epigastric vessels. Now, the indirect inguinal hernia enters through your deep inguinal ring, whereas your direct hernia enters through your Hasselbalch triangle. So, what are your boundaries of Hasselbalch triangle? This is formed laterally by your inferior epigastric artery, medially by your lateral border of your rectus abdominis, and inferiorly by your inguinal ligament. Now, other differences include indirect usually occur in young patients, whereas your direct hernia usually occurs in elderly. Direct is usually bilateral, whereas indirect is usually unilateral. Then your indirect tends to be complete, whereas your direct tends to be incomplete. Then your deep ring occlusion test is positive in case of your indirect hernias, whereas it is negative in case of your direct hernia. So, what is your deep ring occlusion test? So, you occlude the deep ring, that is 1.25 centimeter above the inguinal point, that is ASI between your ASIS and your pubic symphysis. Now, on occlusion, if you have your hernia coming out medially, that is your direct hernia, it is said to be negative. Now, on removal of your occlusion, if the hernia comes out on your cuff impulse, it is your deep ring occlusion test positive, signifying it to be your indirect hernia. Then regarding your classification, the most commonly used classification these days is your EHS classification, which is your European Hernia Society classification. So, we have your P for primary, R for recurrent, L for lateral, M for medial and F for femoral, and then defect size is measured in your finger breadth, that is a 1.5 centimeter. So, for an example, you have your primary indirect inguinal hernia 3 centimeter defect. As per the EHS classification, this would be P, indirect would be your lateral, so it will be L, and then inguinal hernia size of a 3 centimeter, so it would be your 2, as it is measured in 1.5 centimeter. So, it would be your 2. So, the EHS classification will be PL2 for your primary indirect inguinal hernia of a 3 centimeter defect. Now, there are few other classifications which we need to know. So, one is your NIHS classification of your inguinal hernia, where you have your type 1, which is an indirect hernia with an internal inguinal ring of normal size. Then you have type 2, which is your indirect inguinal hernia with a dilated internal inguinal ring. Then you have type 3, which is your posterior inguinal wall defect, 3A being your direct inguinal hernia, 3B being your indirect hernia with enlargement of your internal ring, and 3C being your femoral hernia. Then you have your type 4, which are your recurrent hernia, 4A being direct, 4B being indirect, 4C being infemoral, and 4D being combined. Then you have your Gilbert classification of hernia, where you have type 1, a small defect which is indirect less than 1.5, medium defect 1.5 to 4 centimeter indirect. Then your type 3 is your large defect, that is more than 4 centimeter indirect. Then your type 4 is your entire floor defect or the direct hernia. Then you have 5, which is diverticular type and direct. Then type 6 is your pantaloons or double hernia, and type 7 is your femoral hernia. So, the current classification that we use is your EHS classification. So, please do remember your EHS classification and remember the names of the classification, at least for this inguinal hernia, which is your NIHS classification and your Gilbert classification. So, again, the symptoms would be presenting you with a swelling or the pain in the groin region, and it is a clinical diagnosis mainly, and you do an ultrasonography when you suspect your features of your LUTS and in case of your irreducible hernia, but in general your hernia is a clinical diagnosis. So, the various operations for your inguinal hernia include your herniotomy, open suture repair, which is in form of Bassini, Shouldes, Desarda, malonate down. Then you have your open flat mesh repair, that is your Lichtenstein mesh, tension free mesh hernioplasty. Then you have your open complex mesh repair, which is usually not recommended these days, that include your mesh plugs and your hernia system. Then you have your laparoscopic or your robot assisted repair in form of tip and tap. So, let us discuss the surgical procedures in short. So, first we have your herniotomy. So, what happens in your herniotomy? So, in this we excise and close the sac. It is usually done in your congenital hernia. Then you have your Bassini repair. So, Bassini repair is your open suture repair. Now, so surgeon enters the inguinal canal by opening its anterior wall, external oblique aponeurosis. Now, the spermatic cord is dissected free, and the presence of a lateral or a medial hernia is confirmed. How do you confirm it? You will confirm it with the location of your inferior epigastric artery. Now, then the sac of a lateral hernia is separated from the cord and opened, and if there are any contents, it is reduced. Then the sac is sutured and closed at its neck, and excess sac is removed. Now, if there is a small medial hernia, then the sac is inverted and your transversalis fascia is suture plicated. So, now the sutures are placed between your conjoint tendon above and the inguinal ligament below, extending from the pubic tubercle to your deep inguinal ring, and the posterior wall is strengthened. So, this is what is done in your open suture repair, that is your Bassini repair. Now, you have your Shouldes modification. So, what happens in this Shouldes modification of your Bassini repair? Over here, the transversalis fascia is opened. So, there is opening of the transversalis fascia by a central incision from your deep inguinal ring to your pubic tubercle, and then they are closed to create your two-layered posterior double wall, which is known as your double breasting, and your external oblique aponeurosis is closed in your similar fashion. Then you have your Desarda technique. Now, what happens in your Desarda technique? So, in Desarda, your external oblique aponeurosis 1 to 2 centimeter strip is isolated from your main muscle, but left attached medially and laterally. Now these are sutured to your conjoined tendon and your inguinal ligament, reinforcing your posterior wall. Right. Now the next, which is the most commonly used procedures these days in your hernia repair, which I am sure you must have seen during your final year surgical postings or your internship posting, is your Liechtenstein mesh hernioplasty. The important points are it is tension free, simple, and you use a flat propylene mesh repair. So the basic steps are similar to Bassini, but that after removal of your hernia sac and the closure of your medial defect, a mesh is placed over a posterior wall, usually measuring 8 into 15 centimeter, which is behind the spermatic cord and slit to wrap around the spermatic cord at the deep inguinal ring. Following that, you have your closure of your external oblique aponeurosis and your skin. So this is the diagrammatic representation of your Liechtenstein tension free mesh hernioplasty. You can see over here you have your, look in this diagram, you have your external oblique aponeurosis over here. So you have the structures which are pulled and aside, and then you have your placement of mesh, and the mesh are closed. Then the mesh is not closed, the mesh is fixed down to these structures, and you place it below the spermatic cord, and the spermatic cord is held upwards. Right. So this is a diagrammatic representation of your Liechtenstein mesh hernioplasty. Now a little bit about your laparoscopy. I would want you all to remember at least the names, which is your total extraperitoneal and your transabdominal preperitoneal repair of your hernias. So for laparoscopy, we need to understand few important triangles. Let's not understand the steps in detail, but two important triangles which are your important MCQ point. One is your triangle of doom. So this triangle of doom is bounded medially by your vas deferens, laterally by vessels of spermatic cord, and inferiorly by your peritoneal reflection. The contents include external iliac vessels, femoral nerve, and your genital branch of your genitofemoral nerve. Then you have your triangle of pain. So this is bounded medially by your gonadal vessels, laterally by your peritoneum, and superiorly by your iliopubic tract. The contents are your lateral femoral cutaneous nerve, femoral branch or genitofemoral nerve, and your femoral nerve. Now what are the importance of your triangle of doom and triangle of pain? Now if you place your tackers or clips over here, in case of triangle of doom, you may injure your external iliac vessel, which is going to lead to profuse bleeding. Whereas if you place it in triangle of pain, the patient is going to have intractable pain in your post-operative period. So this is your representation of your triangle of pain and triangle of doom. So what are your benefits of your laparoscopic surgery? So it is used usually in bilateral hernia and recurrence after your open surgery. Now regarding your complications of hernia surgery, your early complication includes your pain, bleeding hematoma or urinary retention, and then you have your medium complication, which includes your seroma and your wound infection, and late complications include your chronic pain and your testicular atrophy due to the entrapment of the nerves and the vessels in your mesh or due to the pressure on it. So this is all about your inguinal hernia. Please remember the boundaries and the anatomy of your inguinal canal. That is one of the most commonly asked questions over here. Then regarding your indirect and your direct inguinal hernia differences and the treatment, that is your mesh hernioplasty, right? And lastly, regarding your complications of hernia surgery, which are your pain, bleeding, urinary retention, seroma, wound infection, chronic pain, and your testicular atrophy. Thank you.